which I want you to know, like bowel gas pattern, extraluminal air, soft tissue masses, and calcification. The bowel gas is usually in the GI tract and it shows different patterns, which I will tell you later. Normal abdominal X-ray. There are certain key factors which should be adopted to have an adequate abdominal X-ray, like it should cover at least the D2 vertebral body, and inferiorly it should cover the complete pelvic rim, at the level of superior pubic symphysis. Now on the right upper quadrant there is liver shadow. You can see 11th and 12th ribs, the inverted triangular sauce margin, hepatic flexure, iliac crest. In the right lower abdomen, gas in the cecum. There is bladder in the pelvis, sacrum, then femoral head, sacroiliac joint, gas in the sigmoid colon, gas in the transverse colon, the left kidney shadow, and the splenic flexure. This is gas in the stomach in the right upper quadrant. What is normal? Stomach gas almost always occur in the left upper quadrant until and unless there is some situs inversus. Then small bowel pattern, which is usually in the center of the abdomen, maximally 2 to 3 loops, and the large bowel, which is always in the rectum or sigmoid, and sometimes if the bowel preparation is good, you can visualize in the periphery of the abdomen. This is descending colon, this is ascending colon, and this is the transverse colon. What is the difference between the large and small bowel on abdominal X-ray? The large bowel loops are usually peripheral, except in the right upper quadrant, which is occupied by the liver, and the haustral margins are seen, and they do not extend from wall to wall. Small bowel is usually in the mid of the X-ray, in mid-abdomen, and you can see the pattern of valvulae conniventis, which extend across the lumen and are closer to each other. The radiographic principles. There are certain series which we acquire in case of acute abdomen or some obstruction. It includes supine film, which is acquired when the patient is lying down with face upward on the couch, upright or left decubitus, it is almost always done, then prone or lateral rectum, sometimes done, and the chest upright or supine. What is the purpose of supine abdomen? We want to evaluate the bowel gas pattern, we want to see the calcification and the masses. In the prone abdominal film, when the patient is lying with face downward, the gas in the rectosigmoid, in the ascending and descending colon is observed, and in the upright abdomen, which is the erect abdominal film, basically we can see the free air and the air fluid levels in cases of obstruction, and upright chest, in which we can see the free air and any lung pathology like the ruptured liver abscess, which can cause consolidation collapse of ipsilateral lung, and also pleural effusion in the pleural cavity on the right side. Then how we acquire the different views? Supine form, the patient lies on his or her back and the X-ray beam is from the top and it lies vertically downward. The X-ray shoot is within seconds and the cassette lies behind the couch. So this is antero-posterior or AP view. Then prone film, the patient lies on his or her abdomen with face downwards and the X-ray beam directed vertically downwards and the cassette is anterior and the X-ray tube posterior. PA view. Patient stands or sits and X-ray beam is directed horizontally and the cassette posterior, X-ray tube is anterior. And the upright chest or erect chest, patient stands or sits, horizontal X-ray beam, cassette anterior and the X-ray tube posterior. Abnormal gas pattern. It can be due to functional ileus in which one or more bowel loops become aperistaltic or hypoperistaltic, and it is due to some local irritation or inflammation. It can be a localized sentinel loop which may involve one or two loops, and it can be generalized when all the small bowel and large bowel loops are involved. Mechanical obstruction. It can be intraluminal, like some stone like appendicolith or some plombage or something, like somebody has eaten some unnatural thing like tuft of hairs or cotton. It can cause mechanical obstruction and it is intraluminal, and it can be extraluminal, means some enlarged lymph node, some mass, some retroperitoneal tumor or some intraperitoneal tumor can cause compression over the bowel loops, resulting in proximal bowel loops obstruction. Mechanical obstruction also can be of a small bowel or the large bowel. We frequently use 369 pattern as it is very easy to remember. Small bowel diameter is usually 3 cm, large bowel 6 cm, and cecum can maximally expand up to 9 cm, and beyond that limit there is a risk of perforation. Localized ileus. When few dilated loops of a small or large bowel are seen, it can be a localized ileus, and sometimes we can see the air fluid level in the sentinel loop. It can be due to some local irritation like some cholecystitis, etc. Gas in the rectum or sigmoid can be seen, and it may resemble early small bowel obstruction. What are the causes of localized ileus? They can be divided according to the site. Suppose if they are in the right upper quadrant, we can suspect cholecystitis. If it is in the left upper quadrant, we can suspect pancreatitis. In the right lower quadrant, appendicitis. In the left lower quadrant, diverticulitis. And in the mid-abdomen, ulcer or some ureteric or renal problem. Colon cutoff sign. What is colon cutoff sign? It is basically the abrupt cutoff of colonic gas column at the splenic flexion. What is splenic flexion? This is the transverse colon, this is the ascending colon, and here is the descending colon. The area and the spleen lies here, the liver lies here. When there is a turn of transverse colon and the start of descending colon, this portion is called splenic flexure, and this is the hepatic flexure. So any inflammatory exudate in cases of acute pancreatitis involves the phrenicocholic ligament, and which is the attachment of the transverse mesocolon. So it is in spasm and mechanical narrowing of the splenic flexure at the level and the retroperitoneum. Generalized ileus, when the entire bowel loops are aperistaltic or hypoperistaltic. Dilated small and large bowel to the rectum with large bowel obstruction, no gas in the rectum or sigmoid, and long air fluid level. It can be seen in post-operative period, usually the abdominal surgeries, within after 1 or 2 days even, and due to some electrolyte imbalance like in ketoacidosis, patients with excessive vomiting or diarrhea or gastroenteritis. Generalized adynamic ileus. The large and the small bowel loops are extensively air-filled but not dilated. Because how I can say not dilated? Because the diameter are within the normal limits. But the small and the large bowel loops looks the same. The pattern is like cannot differentiate much. Mechanical small bowel obstruction. Dilated small bowel and the fighting loops. What are the fighting loops? These are the visible loops lying transversely with air fluid levels at different levels. There is little gas in the colon, especially the rectum. These are the few X-rays taken of the same patient with erect and supine position. This is the small bowel obstruction. You can see the dilated small bowel loops in the mid-abdomen with air fluid level. You can see this is the cutoff. This is the air goes up and the fluid settles down, and these are in the mid-abdomen. How can we say this is a small bowel? We can see the these are the valvulae conniventis and the bowel loops are in the mid-abdomen. Then the supine, you can see this whole dilated bowel loops, and this is the contrast filled urinary bladder. Maybe the patient had some IV injection or some barium which is not excreted properly and ultimately reabsorbed and comes into the pelvic ileal system. What are the causes of mechanical small bowel obstruction? Adhesions on the top, then hernia, malignancy, gallstone ileus, intussusception, and inflammatory bowel disease. They are usually seen on the X-rays. There are few signs like step ladder appearance, in which there are loops arrange themselves from left upper quadrant to the right lower quadrant in the distal small bowel obstruction. You can see the stomach bubble which is also distended and air in the enlarged bowel like dilated bowel loops. Then coil spring sign. Have you ever seen the coil? It opens and it closes like, you can see this thing. This is like a coil. A small bowel valvulae conniventis looks like a coil. So this is the point of obstruction. Then a string of pearls. You can see small specks along the periphery of the bowel loops. You can see this one, and the dilated bowel loops with valvulae conniventis and air fluid level. Then stretch or slit sign. You can see the valvulae conniventis are are far away, like they are open, the coil is open. This is called the slit sign, one of the sign of a small bowel obstruction. Then closed loop obstruction, when the 2 points of the same loop of the bowel obstructed at a single location, forming C or U, C. The term applies to the small bowel usually caused by adhesion, but in large bowel the same thing is called volvulus. Crescent sign. Have you seen the moon? On the first or second date it is like a crescent. This one is crescent. And in the left upper quadrant, soft tissue mass or head of intussusception in distal transverse colon. Then in children, infant, within first few weeks, there might be a double bubble sign. This one is in the stomach bubble, and another is the dilated duodenal loop, and the no distal air. You cannot see any air in the distal bowel loops or mid or distal abdomen, so it can be a case of duodenal atresia. Child has repeated bilious vomiting. Mechanical large bowel obstruction. You can see the gas pattern in the periphery of the abdomen as well, sometime in the mid abdomen also, and the colon dilates from point of obstruction backwards. There is little or no air fluid level in the large bowel obstruction because the colon absorbs all the fluid, and no air in the rectum or sigmoid. In the large bowel loops, as the bowel loops tend not to overlap, therefore it is possible to identify the site of obstruction, like in this case the ascending colon, and the transverse is also distended, and you can see here some mass. In this case there is no gas in the small bowel because the ileocecal valve is competent. If it is incompetent, then the large bowel is not dilated and it decompresses into the small bowel and looks like a small bowel obstruction, although it is a large bowel obstruction. Some causes of mechanical large bowel obstruction: it can be due to some tumor, volvulus, hernia, diverticulitis, or intussusception. Volvulus. Sigmoid colon has its own mesentery and therefore it is more prone to twisting. Cecum is usually retroperitoneal and not prone to twisting, but the 20% people have defect in the peritoneum that covers the cecum, resulting in a mobile cecum. So we can have cecal volvulus and we can have sigmoid volvulus. You can see the area of twist, and the dilated cecum is like away from the point, and the sigmoid volvulus, this is the area of twist, so the dilated loop goes upward. This is cecal volvulus, this is sigmoid volvulus. Coffee bean sign. It is seen in sigmoid volvulus. You can see this inverted U or coffee bean sign. Coffee bean, have you seen coffee bean? Any of you? You can see a small dimple and uncovered area in the mid of the coffee bean, and this is the massively dilated sigmoid loop. Sometimes there are hernia which are due to the anterior abdominal wall defect, and the bowel loops herniate through the defect subcutaneously and lies just beneath the anterior abdominal wall. and there is a greater chance of an air entering into the herniated bowel loops because it is the least dependent part of the bowel, especially in the supine position. So we have shooted it into the lateral decubitus of value. You can see the hernia, the dilated loop just beneath the anterior abdominal wall. Then we can also have contrast studies in the abdominal X-rays, or we can use two types of contrast medium. It can be the barium or it can be the gastrographin. Usually in obstruction we prefer to give gastrographin because barium is a thicker compound, and the water is, if there is some obstruction, then the water is absorbed because the bowel transition time is increased and the residual barium is like a stone, so it will further aggravate the obstruction. So we give the gastrographin, which is soluble and easily evacuated, and if it is left, it will not form any clump or anything to obstruct further. Usually the apple core sign you have heard, you have seen the apple core. All of us have eaten the apple many times and left the core. So it is the radiological manifestation of a focal stricture of the bowel, usually at contrast material enema examination. The structure demonstrates shouldered margins and the core in between, and the mucosa is irregular. It is usually seen in the annular carcinoma of the colon. This is the barium enema examination. We can have barium swallow for evaluating the pathologies of esophagus. We can have barium meal to evaluate the pathology of stomach and duodenum. We can have small bowel enema for the small bowel pathologies and large bowel enema for the large bowel pathologies. Small bowel enema is sometimes called small bowel follow-through series. We can use air admixed with the contrast in the barium meal or swallow in the form of an Eno sachet, and in the barium enema we inject at least 50 to 100 cc of air per rectally. This is the barium swallow examination. We can see the dilated esophagus with irregular aperistaltic mode, and however no ulceration is seen. The transit time is delayed. It is a case of scleroderma. Then massively dilated contrast filled single contrast. We haven't given Eno sachet in this patient, and you can see the abrupt narrowing at the distal gastroesophageal junction, and however little contrast is passed through the gastroesophageal junction into the stomach, and the narrowed distal esophagus is seen, which is called red tail sign. It is a pathognomic for achalasia. Then barium meal examination. We have to acquire different views like oblique, like AP, like posterior anterior, right posterior anterior, left posterior anterior, different views, right oblique, left oblique, different views according to the situation, because we continuously record this barium meal procedure, and according to the patient and according to the condition we take different views. You can see the normal stomach, normal mucosal pattern. This is the collection of contrast because on the dependent part, but in this diagram you can see the normal folds are thickened, gastric rugae are thickened, and there are you can see multiple and rather punctate erosions in this pattern with central dot, hollow dot, and peripheral pooling of contrast. It is a case of gastritis with gastric ulcer. This is the beautiful barium enema examination. You can see the opacification of the rectum, then the descending colon, transverse colon, ascending colon. But in the ascending colon, you see the cecum is like along the eyelid blade. Why it is so high up? It is usually, and it is narrowed, ileocecal junction is so much narrowed and irregular. It is a case of intestinal tuberculosis, ileocecal tuberculosis, which is very common in our society, and it will result in high up cecum with thickening of the ileocecal junction. Thumb printing is another pattern which we observe. In the bowel loops, you can see this thing, thumb printing. The wall is so much thickened, it will create this pattern. The haustral fold are thickened and acquiring the pattern, thumb printing pattern, usually in the bowel ischemia. Then again barium enema, double contrast. You can see the rectum. You can see this side the ascending colon, this is the transverse colon, and when you see on the left there is a haustral pattern of the bowel loop, and it looks like a lead pipe, and it is also narrowed. So this is the case of inflammatory bowel disease, and you see this pattern in ulcerative colitis. Now the extraluminal layer. Extraluminal layer can be in the pneumoperitoneum form, which is intraperitoneal layer. It can be retroperitoneal. It can be in the bowel wall, because intraluminal layer is normal, but even if it is in the bowel loop, in the bowel wall, it becomes abnormal. In the GI series, the air can be seen in the biliary system, which is called pneumobilia. Upright or erect film is the best to detect it. We ask the patient to rest for 10 to 20 minutes, so the maximum air goes upward, and then we can acquire erect chest X-ray, or this allows the free intra-abdominal air to rise up, and a crescent is formed just beneath the diaphragm. 1 ml of gas can be detected in this way if the patient was given enough time to rest, and then the X-ray is acquired. What are the causes of free air? It can be due to some rupture of the hollow viscus, which can be a peptic ulcer, it can be post-traumatic, it can be due to perforated diverticulitis or perforated carcinoma, or the patient might be post-operative, 5 to 7 days normal, and it should get less with successive studies. What are the signs of free air? Crescent sign, Chilaiditi sign, regular sign, football sign, falciform ligament sign, triangle sign, and cupola sign. Also the lesser sex sign. Crescent I have already told you. Every one of you have seen the crescent. Now we are about to see the crescent of Ramadan, Alhamdulillah. It is best demonstrated on the upright chest X-rays or left lateral decubitus, and easier to see under the right hemidiaphragm, because under the left hemidiaphragm there is a stomach bubble also seen. So some people mistaken it. Chilaiditi sign. It may mimic under the diaphragm and we have to look for the haustral fold to rule out. Usually the patient are cirrhotic with flattened hemidiaphragms due to some lung hyperinflation, and an area is created with the upper abdomen above the liver. This space may be filled by the bowel, and we can see the bowel is air filled, then it may mimic free gas. This thing. Chilatity sign. Regular sign. If we can visualize both sides of the bowel, it is a sign of pneumoperitoneum, because one patron is intraluminal air and the another is extraluminal air. Usually there is large amount of free air and may be confused with the overlapping bowel loops. Football sign. When there is massive pneumoperitoneum, we can see it. You can see all around the abdomen there is air, free air. You can see most often in children with necrotizing enterocolitis. In the supine position, air collects anterior to the abdominal viscera. Then falciform ligament sign. You can see this thing. It is normally invisible, but in supine film, free air rises over the anterior surface of the liver, and you can see this sign. Continuous diaphragm sign. If the sufficient free air is present under both left and right hemidiaphragms, then you can see this sign. This is the left hemidiaphragm, this is the right hemidiaphragm, this is the free air, this is the stomach bubble, and you cannot see any gap between the left and right hemidiaphragm. This is hard. Lesser sac sign and cupola sign. First, lesser sac sign. The lesser sac is positioned posterior to the stomach and usually a potential space. So any free connection between the lesser sac and the greater sac through the foramen of von Slow can create this thing. You can see this. And the cupola sign, when the air is superior to the left lobe of the liver, left lobe is under the left hemidiaphragm, so you can see this. Retroperitoneal air, when it is outlining the kidneys or sauce, it can give a mottled, blotchy appearance and relatively fixed position. It can be around sauce muscle, kidneys, ureter, bladder, aorta, IVC, or in the subphrenic spaces. Causes may be bowel perforation like appendix perforate and ileal or colonic perforation, blunt trauma, penetrating traumas which can give injury to the pancreas, iatrogenic, it can be due to some foreign body, gunshot, and gas producing infections. Pneumoperitoneum. In the retroperitoneal space, you can see the air, free air outlining the kidney, right kidney, and the regular sign. Here in the bowel wall, it is seen in profile, producing a linear lucency that parallels the bowel, and air and face has a mottled appearance, resembling gas mixed with feculent material. What are the causes of air in the bowel? It can be primary nematosis stroids intestinalis, which is rare and usually affect the left colon, and it produces cyst-like collections of air in the submucosa or serosa. It can be secondary to some diseases with the bowel wall necrosis or any obstructing lesions of the bowel that raise the intraluminal pressure. Complications are the rupture into the peritoneal cavity and dissection of air into the portal venous system. Nematosis intestinalis. You can see the air outlining the serosa. Then pneumopedia. You can see the branching pattern in the right upper quadrant It can be seen after some procedure like some sphincterotomy or some CBD stricture, ERCP or CBD stricture removal or something. Soft tissue masses. These X-ray taken for to evaluate some soft tissue masses is obsolete now because of the so much other modalities like CT, ultrasound, and the MRI. But in the periphery of the country, in some villages, this practice is still going on because of the lack of the adequate facilities. Abdominal calcifications. We have to identify the pattern, whether it is peripheral, it is central, it is linear, it is amorphous. It can be vascular, it can be hepatic, it can be in the gallbladder, it can be in the spleen, pancreas, lymph nodes, adrenals, kidneys, ureter, bladder, prostate. In the right upper quadrant, you see a well-defined lesion with peripheral areas of calcification. So this is a case of highlighted cyst which is calcified. Cyst can be renal, splenic or hepatic. Then peripheral calcifications can be in the aneurysm, which can be aortic, splenic or renal, and some secular organs in the gallbladder or urinary bladder. Linear or tract calcification, it is usually seen in the walls of the tubular structures like aorta, iliac vessels, IVC, fallopian tubes, vas deferens and ureter. You can see in the previous image I have shown you the calcification of the aorta. This is the lateral view. You can see the vertebra, and in front there is the vessel aorta. You can see the peripheral calcification. Then in the X-ray pelvis, you can see the calcification of vas deferens. These are normal. Calcified enteric lymph nodes. You can see it is a benign finding, but usually in cases of tuberculous adenitis, we can also observe. Then some calcified fibroids you can see in the pelvis, and calcification of the pancreas, usually seen in recurrent pancreatitis. Bladder calculi, you can see this is the image of the urinary bladder, and you can see these calculi. Then in the renal area, when we have the X-ray KUB, there is a pelvic calyceal system calcification or calculus. Staghorn calculus, you can this pattern, you can see the staghorn pattern. You can see the enlarged kidney with a large calculus. Then nephrocalcinosis. There are multiple areas of calcification in both kidneys involving both cortex and medulla. So the nephrocalcinosis can be cortical or medullary, different causes, like in this case it is a case of medullary sponge kidney. Putty kidney is this thing, calcified kidney. It is pathognomonic for tuberculosis, and basically there is a necrotic material which causes autonephrectomy, and the kidney is shrunken, is small, with dystrophic calcification. Then you can see the calcified gallstones in the right upper quadrant. This is the contrast study again, IVP, intravenous pyelography, in which we give urographin and we evaluate the function of the kidneys. On the right side we can see the normal pattern of papillae and calyces. Then the renal pelvis, then the ureter, and it goes into the bladder. But on the left side, the system is dilated and there is abrupt narrowing at the pelviureteric junction, and we cannot visualize the ureter, so there is some obstruction in this area with proximal hydronephrosis. So what is the conclusion? Conclusion is approach to abdominal X-ray should include Getz pattern, extraluminal air, soft tissues and calcifications, and named radiological signs are a useful way of remembering, identifying and reporting on the films.